I'm Joanne Hatchett from PSC Partners, and it is such a pleasure to welcome everyone and get started on our Canadian Paediatric PSC Day today. Thank you, this is great. On behalf of PSC Partners and founder and CEO Ricky Safer, who was unable to attend this morning in person because she's traveling to attend EASL, the European Association of the Study for Liver Disease meeting. We welcome each of you. Today is so exciting to be together with teens and parents, with dedicated and knowledgeable pediatric researchers and clinicians, friends and family, focused on pediatric PSC, leads us to this special, unique day. Thank you for being here, and welcome to all of our virtual attendees. We do have virtual attendees. We hope that they'll ask us questions and participate. As you all know, PSC Partners and PSC Partners Canada are two organizations that work seamlessly together. Thank you to Mary Vias. Mary, would you want to stand? Say hi. So thanks to Mary, President of PSC Partners Canada and mother of her son who lives with PSC, and to Jessica Travis, yay Jessica, event planner and post-transplant recipient. Thank you both for organizing this wonderful event. Today is a day to be with your community, which for many people becomes their second family. When I traveled to my first PSC Partners conference in 2006, which was the second annual conference, I arrived anxious and uncertain a few weeks after my 15-year-old son's diagnosis of UC and PSC. I left the meeting feeling like I had met my second family. I hope each of you enjoy seeing people today who you may have met in person at a conference or virtually through a PSC Partners webinar or peer Zoom room. For those who are newcomers, everyone in this room, parents, teens, researchers, and clinicians, we welcome you and are thrilled you're here. I hope you enjoy every moment of being with others who understand and know, and we all will remember forever that feeling of being a newcomer. We welcome you and hope that you enjoy participating today in both the conference and the peer group breakouts. Of utmost importance is why we are here. Thank you to each of our speakers, researchers, and clinicians who are in attendance. In addition, I include the fellows who are with us. Thank you all for joining us on your Saturday morning. The importance of pediatric PSC and IBD research and patient family support is vital. I can't wait to hear about new research, learning about insights, projects, discussing the importance of support and mental health, and for you to meet and interact with the experts who think and focus on PSC every day. At least most of the doctors, I think, focus on PSC most days. And we will give you a vacation day. For those who are new, please don't be shy. Ask questions, enjoy being with others who remember how it feels to be a newcomer, and know that we all support and care about you and your family. Also, if you haven't heard, the 20th anniversary PSC Partners Annual Conference is October 18th to 20th in Phoenix, Arizona, offering 2.5 days of sharing, learning, and support that you won't want to miss. Travel ships are available for this conference. Feel free to check the PSC Partners website or ask me and I'll point it out to you. And I want to thank you and have everybody enjoy today. Mary?
Thank you so much, Joanne. And I just want to say, Joanne is one of the staff at PSC Partners who has the largest heart, which you probably have already picked up on. And anyway, thank you, Joanne, for those words. And if anybody needs anything, Joanne is an incredible go-to person. Her many decades of caring for patients as a nurse practitioner shows in the love that she provides the PSC Partners community. So there it is. It takes a village. So I just wanted to quickly mention all the people in this room. It takes a lot of people to make one of these things happen. We have with us today 2 of the board of directors here in person, Eve Jedrzejewska and Sandy Van Ostrand. We have, I believe, one of the board members is joining us online, Rachel Gomel. We have staff here. Jessica Travis is the event planner. Joanne Hatchett, medical science liaison, came from California to support us. And we have a crew of volunteers. So again, for the newcomers, there are a bunch of people who either are parents who have a pediatric PSCer who now are young adults here. We have some young adults who were pediatric PSCers who are volunteering. And we have people living with PSC here, adults who are happy to be here for you. So introduce yourselves to some of the volunteers, please. And then we also, as Joanne mentioned, we have a number of GI fellows joining us today, so welcome. I just want to take a minute and go through some logistics before we kick off our content. You all should have a copy of the agenda in your bag. So if you did not collect a bag, you can go do that at the registration desk. And a comment for the speakers and also for the attendees. During the Q&A, we are streaming this meeting, and we have attendees participating on a Zoom webinar, and so it's really important to speak into the microphone. And for the questions, we will have people roaming with microphones, so please ask your question into the microphone so the online attendees can hear it. We also have ASL and French interpreters, so speakers, make sure to leave some pauses for the interpreters. Thank you. And then I'd like to invite you, especially those for whom this is your first patient event, please take care of yourselves. My experience as a parent with a young adult living with PSC is that these events are incredibly meaningful and supportive and unexpectedly fun, but can be emotional at times, which I already felt listening to Joanne's opening. And you are all welcome to take care of yourselves. Please come and go as needed. And the friendly group of volunteers include many who, as I said, are personally affected by PSC, so don't hesitate to ask for support. Finally, photos. We have a photographer here, Norman, there in the back, and we will be taking photos of the event. We have carefully noted those who have declined the photo release, so please don't worry if your image is captured. We will be making sure those do not get shared out. But if we're taking a group photo, it will save us time if you all would take a moment to just, if you remember, turn your name tag around, because your privacy is very important to us. So any images that we do use, we do blur out your names on your name tags, and it just saves us a lot of time. Thank you for your cooperation with the masks and sanitation. This is a wellness precaution for those who are or have family who are immunocompromised to remain as healthy as possible. You'll find hand sanitizer stations throughout the venue and extra masks if you need them at the front. Bathrooms are downstairs. There's an elevator to the right in the lounge when you exit if you need an elevator. When we do breakout rooms, there is one room upstairs that the teen group will be going to. Otherwise, everything will be on the ground floor here. And there's the shop. Don't forget to visit the shop, and don't forget to visit Albert, who you're going to meet in this session, who will be doing his virtual reality experience in the room to the left when you exit. And we have, sorry, one more reminder. Yeah. This is Jess.
Hi. Just one reminder for the speakers. If you look at the back, we will have somebody who will be flagging you about 5 minutes to when you're supposed to end. Okay.
And we're using Slido today. So those in the room, you are welcome to raise your hand. We will bring you a mic, and you can ask your questions. If you are more comfortable putting your question into Slido, you can type it into Slido. You can go to Slido by capturing this QR code. You're looking for PSCP as the code, and your questions will show up on the screen. And for our online attendees, please use Slido to submit your questions for the Q&A. And before we kick off today's sessions, I would like to take a moment to recognize that we live, work, and learn on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And this is now home to many diverse First Nations, Inuit, and Métis peoples. PSC Partners Canada is based in Toronto, which is covered by treaties signed with multiple Indigenous bands. We offer this land acknowledgement as an act of reconciliation with the Indigenous peoples of Canada. Okay, so Joanne, back to you to introduce our first speaker.
It's my pleasure to Thank you. My pleasure to introduce Dr. Gideon Hirschfield, who holds the inaugural Lily and Terry Horner Chair in Autoimmune Liver Disease at the University of Toronto. He's the Director of Autoimmune Liver Disease Program and the Director of the Clinical Practice at Toronto Centre for Liver Disease, Francis Family Liver Clinic, and specializes in primary biliary cholangitis, primary sclerosing cholangitis, autoimmune hepatitis, and transplant. Dr. Hirschfield?
Morning. Thank you very much. So it's obviously a pleasure to be here on a Saturday morning, and you might be wondering why an adult doctor is starting off this great day for you. And really what my job is, and it won't be as sophisticated as the virtual reality, is to give you some of the basics of this disease that many of you are living with, either as a patient or as a parent or as a sibling or as a friend. And, you know, I've been sort of involved in autoimmune liver disease, which is the family of what we call these diseases, for about 20 years now. And at the adult end, Toronto General Hospital, we have a big liver program, and we work very closely with our colleagues at Sick Kids. And what we do is we make sure that the patients who graduate from Sick Kids move over to the General, and that's the reason why perhaps I'm starting it. And what we have is a program which is really focused on these rare liver diseases, amongst PSC being one of the most prominent, where we look after patients from across all of Ontario and sometimes outside of the province, in fact, and help them live with their disease, help them get the best care, we hope, help them access the best clinical trials, and also help them, contribute back, collaborations with charities and research and pharma into research, because obviously what we really want is to go beyond the basics and get into the point of understanding this disease. So, you will see lots of pictures today. We'll start off with the real simple aspects of, PSC. So you've just got your roadmap for the rest of the day to understand what it means to have inflammation in your medium to large bile ducts that leads to narrowing and that leads to potentially inflammation in the liver itself. The liver's on the right, the spleen's on the left, okay, and for a hepatologist, the liver's the best organ. We always make fun of, the simple pump of the heart, and the kidney's just a filter device. But if you really want sophistication, you need to think about how the liver works. And what the liver does is it sits there all day making things and excreting things. And it does it for anything that is being fed from blood from your bowel, which therefore is anything that you've been exposed to, that you've eaten, but also any medicines you've taken, any toxins that you've seen as you've been breathing, will ultimately be metabolized and looked after in the liver. And the liver is this amazing organ that in health is incredibly forgiving. Which is why, when we look at transplantation, you can actually take a liver from an 80-year-old and donate it to an 18-year-old. And if that 80-year-old was healthy, that liver will work. Okay? And so under normal circumstances, and in fact under all circumstances, the liver's very forgiving. And the liver, it's a bit bright, the light, but the liver's got liver cells and it's got bile ducts, and they sit together. You can't take your bile ducts away from your liver. They're all together. And the bile ducts are probably best shown. I've just used the ones in orange, just let you see what bile ducts look like. And they're a series of tubes that essentially are draining bile that's being made by liver cells so that that bile can get into your bowel. Okay? Because bile is very important for digestion, and it's also very important as a chemical for signaling inflammation, stopping scarring, fighting bugs. And normally what happens is your bile is flowing, you make around 600 mils of bile a day, and it goes into your bowel, and basically, that's the normal situation. And then obviously in this disease is attacking those bile ducts. And the inflammation coming from your immune system is attacking those bile ducts. If you focus on the bottom part, again, on the left is what your MRI looks like. Everyone with PSCs usually had an MRI at some point. On the right is just clever computer graphics. Okay, it's still the same, it's just processed images. Okay, but essentially those bile ducts are inflamed, and if they're inflamed, the bile doesn't drain as well, and that's the source of our problems, inflammation in the bile ducts that we don't know the cause of, that people live with for decades and decades and decades and decades, and just sometimes needs a little bit of help from your friendly hepatologist to make that an ongoing success story. If you were to stick a telescope into a bile duct, and you can. We don't do it very often. We have one colleague who does it for us at St. Mike's, who is a real friend of PSC patients, in fact 2 colleagues, and they help a lot of our patients in the city and the province with ERCP, where you look into the bile duct. If you look into the bile duct and you use a camera, you can see, again, the light's a little bit bright, but if you just really focus on C, okay, that is someone's bile duct that is inflamed because they have got PSC. So you can see why some, not all patients, but some patients with PSC will have pain, okay? Their bile duct is inflamed and it is really sore. Okay, and that is a bit like having a sore on your skin. Okay, it's buried within your bile ducts. You've got lots of bile ducts, so not everyone has a bile duct that looks that inflamed all the time. Okay, but that's how inflamed it can become. Okay, no wonder that hurts. No wonder that narrows. No wonder that can then cause problems when the bile doesn't flow correctly. If you look on the picture on the right-hand side, what you're seeing is what it looks like when you look under the microscope. So in the center of that is a bile duct, and surrounding that bile duct is scar tissue. Okay? And scar tissue is what you get when you have long-term inflammation. You live with this disease for decades and decades and decades and decades. The inflammation continues at a low level, but eventually there's going to be scarring around the bile ducts. So we've got inside there's inflammation, really sore, and outside we've got scarring, okay? And that's a problem, okay? No one wants that problem, but it's a problem for us all to solve together. This is just me playing with our new computer at work, okay? We're very proud that our goal is to be we are the biggest program in America for PSC, and we intend to continue to grow. I don't think we've ever turned down a referral to see someone with PSC. I've got a colleague, I've got a few fellows, I've got PhDs, and I've got a team of amazing research coordinators, and we look after more than 600 people living with PSC and continue to grow. I divided it by their age, okay, to look at what it looks like for the patients who come to our clinic, okay? And just to give you some sense, there is a difference between how many boys get this disease and how many girls get this disease. It's generally a disease that's more common in men, okay? That changes actually as you get into much older, 50, 60, 70-year-olds, it becomes more even. But it's certainly, when you're younger, 7 out of 10 patients will be boys and 3 out of 10 will be girls. These are our under 25-year-old patients, okay? Half of our patients are taking Ursodiol, which means that half of them are not, which tells you Half of us think it works, and half of us think it doesn't work. Okay, so it's a throw of the dice. Okay, 1 in 5 of our patients have got scarring of their liver. Okay, because of the inflammation that they've had. Okay, 1 in 10 to 1 in 20 have been told they've also got autoimmune hepatitis. That's a topic for another whole day, okay? But they've got inflammation that looks like a second autoimmune disease. And if you look, that's much more common in the young patients than it is in the old patients. By the time you're 50, 60, 70, you're not allowed to say old, are you, Mary? Okay, but I mean, as you basically are old, okay, the chance that there's autoimmune hepatitis goes down. And that's because when this disease presents in children, it starts with a flurry of activity that's very inflamed, often looks like autoimmune hepatitis, but over time, really the disease is still the disease. Okay? And this is, I can see Amanda looking at me. This is, who's my colleague from Sick Kids, this is literally just unbiased coding, so I haven't even biased the answer. Okay? But there's a gradient. Age is very important to what happens for people. 2/3 of you will have inflammation in your colon. It's the same disease. Inflammation in your colon, inflammation in your bile ducts, okay? And 1/3 of you, I'm pleased to say, because you come from Sick Kids, will be on really, really clever drugs for your IBD already. And that number's growing as our colleagues get better and better at managing the colitis. They are giving you state-of-the-art care with the latest medicines if you need them, okay? And 1 in 10 of our patients who come to our adult program are under the age of 25, okay? So as across our entire clinic, you're the youngest group of our patients. So what I thought I'd do is to go through the basics, is go through this infographic that we drew a few years ago called the 6 C's of PSC, okay? Which is a way to try and understand some of the things that you will read about if you do Dr. Google. And it's very hard for people not to Dr. Google. It's particularly hard for mothers not to Dr. Google when they can't sleep. And you can while away many hours between 12 o'clock and 4 o'clock in the morning on your mobile phone, okay? And it will take you to amazing places, okay? Now, whether or not all those places are real is debatable. Lots of the information is very good, and many of you will start at PSC Partners and learn from that direction, okay? But that's what's the concept of the 6 C's. And I want to finish on the last C, which is cure, which came from PSC Partners. So, this is the disease of liver and bowel, okay? There's your bile ducts, there's your bowel. Your liver and bowel are talking to each other, okay? They talk to each other forwards, liver to bowel, bowel to liver, okay? It's one disease largely. It's the same disease. It's just that your bowel is broad, your bile ducts are tiny, okay? And therefore the consequence of inflammation in your bile ducts is much more significant, and it's a lot easier for us to poke around your bowel than it is for us to poke around your bile ducts. But it's the same disease, inflammation, okay? Not everyone will know you've got PSC. It can be covert, okay? Some of the symptoms that you have may only be picked up if someone asks you. You're tired, you're itchy, you've got abdominal discomfort that no one understands, okay? Your blood tests are slightly squiffy, but you can't describe that to a friend or a family because they don't understand even where the liver is, okay? So for a long time, living with this disease is a little bit secret, okay? It's covert. It is inflammation of the bile ducts. That's why we call it cholangitis. That's inflammation that leads to scarring, that leads to an inability for the bile to get out to where it needs to be. So the bile hangs around in the liver. Bile's a detergent. Detergents are toxic. If you keep dropping drops of detergent on your liver, you'll get scar tissue, in essence. And there's lots of reasons. You've done nothing wrong. Your genes, your environment, the bugs in your bowel, how they all come together to make how loud that party is. And in the case of PSC IBD, the party is very inflamed, very loud, but it's also persistent, and that's what causes the damage over decades. There is colitis, which is the inflammation in the colon. As I said, it's really the same, okay? It's just a different part of your body that's inflamed, okay? It's inflamed, and that's why you often have a liver doctor and a bowel doctor, and we work together to manage your colitis and your cholangitis. It's all one thing. What do we not want? We don't want cirrhosis. Okay, cirrhosis is when you get scar tissue. Scar tissue is when the liver then doesn't function as well. When the liver doesn't function as well, that's when we think about replacement therapy, which we're very good at as it happens. Okay, and new livers are phenomenal and they work very well. Okay, for the mothers and fathers in the room, they will focus in on Dr. Google and the word cancer. Okay, that's what adults do. Okay, but the vast majority of people living with PSC will never develop cancer. They will never develop cancer because it's very rare, and also because we spend a lot of time trying to pick it up long before it happens. But it's a reality of having inflammation for decades and decades and decades, that's what the body does sometimes. And then finally, cure. That's what we want. That's why we want our patients to be partners. That's why we want you all to take part in research. That's why we're always after your blood. We might be after your stool. We might be after your urine. We might be after your liver biopsy. We're going to look at your liver if it comes out after transplant. We're going to talk about all the trials that we're doing. Okay? So that is PSC at a high level. It's a long journey for you. It's a journey that's got different peaks and troughs. You know, and at different stages in your career of having this disease, whether you're the patient or the parent, there will be highs and lows, okay? But if you work together, then that journey doesn't have to only have negatives, okay? We think you can advocate for yourself about having PSC and how to live with it, you know, which is about advocating for your doctors about clear diagnosis, choices about the treatments that you have, where we know things, where we don't know things. Managing your symptoms because they're real and they're impactful. Thinking about the things that you don't want to think about and how to prevent them. And for us, we have made huge inroads in liver disease, in other liver diseases, where we've cured them or we've controlled them. And we believe it must be possible to do the same for PSC. And we believe it's possible to do that if we put our flag up and say that there are PSC specialist centers, that there are people who want to look after patients with PSC, and that collectively, when you come to clinic, you're contributing for yourself, okay, and for the community, which is why you're here today. And I probably was a few minutes over, Jess, but...
You win an award. You were not over. You were wonderful. Thank you so much. All right, thanks. Albert is next. I would like to introduce Albert Fung, who graduated from the University of Toronto with a master's degree in biomedical communications in 2010. He's currently serving as team lead of the Toronto Video Atlas of Surgery project, headed by Dr. Ian McGilvery at Toronto General Hospital. The Video Atlas project aims to deliver surgical education to trainees worldwide through innovative cutting-edge technology and media, including high-definition surgical footage, 3D computer animation, and most recently, augmented and virtual reality. Albert has taken an active role in developing experimental virtual reality modules for use in surgical education as well as surgical planning. And there are some select modules which you can see in a code link on the speaker bio page. Alfred?
Can everyone see me? And you can hear me on the audio, yes? Perfect. Thank you so much for your patience, and thank you for taking part in this experimental way of presenting. So as Joanne mentioned, my name is Albert. I do not look like this in real life. I look like that. So feel free to look for me. I work with a team of surgeons, Dr. Ian McGilvery and also Dr. Sonia Partland, who is here today, over at Toronto General Hospital. One of our kind of bigger projects is what we call the Toronto Video Atlas of Surgery. So this is a online kind of library of surgical procedures that are done at Toronto General, mostly on the liver, the bile ducts, and the pancreas, but also on transplant. And what makes it unique is we actually try to incorporate a lot of computer animation into these teaching education videos. And we found that using these models has been quite useful for patient education, but more importantly, using those same assets in a new environment, for example, virtual reality, which we're hoping to demonstrate today. And what that kind of looks like is basically if we have a 3D model of the liver. Wait. Oh, there it is. Good. It makes a lot of sense to kind of manipulate it and look at it in 3D because it is a 3D model in your body. And we find that it's kind of helpful to go through a lot of the anatomy of the liver, of the bile ducts in this environment. So let me just jump into another program, and I'll be going through some of the anatomy, as Dr. Hirschfield has mentioned before, of the wonderful organ that is the liver. And let me just jump really quickly. Here. I hope you guys can see this. This is just my hands for some reason. Okay, let's try that. Try that again. Oh, interesting. It's just my hands. That's not useful at all. Hold on. We have a saying in the tech world called Murphy's Law, and it's basically what can go wrong will go wrong, which you're experiencing right now. I apologize, but hopefully this will be our last. Okay. Close enough. You guys can see my hands? You can see the liver? Perfect. Okay, here we go. All right. So this is a virtual model of a liver that we actually modeled after a patient. And imagine that the patient's actually looking right at you. So this is their right, whoa. This is their right side, and this is their left side, just flip from us. As Dr. Hirschfield mentioned, the liver is on your right side. So this is the right triangular kind of organ over here. And on the other side, you can actually see the stomach here. And then on the bottom is your small intestines and the bowels. What I'm going to do is I'm going to take away certain structures just so we can focus. So I'm going to take away most of that. And now we can actually look at the liver, as it were. And if you look at it kind of on the bottom like this, you can see a lot of these blood vessels kind of going into the liver. And you can also look at the top here. You see this blue structure here. That's one of the veins that kind of leads away, or blood away from the liver. That's also, it's actually kind of hard to see, so why don't we just turn the liver transparent? You can blow that up a little bit and kind of take a look at the anatomy inside. So you can see all those vessels that went into the liver. You have your arteries, the portal vein, you have the green bile ducts, and also the blue hepatic veins there. We'll go through those one by one. So let me just turn off a lot of these. And we'll start with the arteries, right? So the arteries are important in transporting blood to various organs, and this actually happens starting from this really big column of blood here. This is called the aorta. This is the biggest artery in your body. And you can start seeing a little branch that kind of comes into the liver. That's what we call the hepatic artery, and that delivers very oxygen-rich blood into your liver so that it can do all the really cool things that it does. The liver is also very unique in that it has a second blood system that feeds into it. This is the portal venous system. We look at it like this, right? So when we mention, there's a connection between the liver and the bowel, and one of which is the portal vein. So once you eat, your food's digested, and then all the nutrients kind of follow this portal vein here from your bowel, and then goes into your liver. It branches into smaller branches like this, and then your liver decides to do, what to do with all these nutrients. Do we store them? Do we detoxify them? Things like that. But that ultimately comes from this kind of purple highway, if you will. Now, both of these blood systems deliver into the liver. Blood needs to come out, right? So this is why we have the third system here called the hepatic vein system. If we look at it kind of on top like this, you can see like very distinct branches. So one on the left here, one in the middle here, and then one on the right there. So this is kind of like the main branching of your hepatic veins. But what those do is they basically kind of feed all that blood that came into the liver back into this huge, yes, got it, thank you, back into this big column here, and that feeds back to the blood, feeds back to the heart, and restarts the entire circulation all over again. So that's kind of your blood in the liver and a little bit of overview. But of course, today we're here to talk about bile ducts. So let me just turn all that off. Oop. Okay, so bile ducts. This is kind of a standard configuration of bile ducts in the liver. So you have the liver making a lot of these bile products, and they go from the smaller ducts here into bigger ducts. And then eventually, you get to a certain point here where it can actually go one or two ways. It can either go into this big balloon here called the gallbladder, or it can go out this huge duct here. This is the biggest duct in your body called the common bile duct, and that would go into your digestive system to help with digestion. One of the things that are seen in PSC patients is something like this. So notice, within the ducts here, I'll bring it a little bit closer so we can see. Pay attention to these two arrows here. So the red kind of denotes that narrowing of the bile duct. All the inflammation, all the strictures that kind of limit the flow there. And then right next to it, you see the blue arrow. That's the dilation. So there's a little bit of a ballooning of the duct opposite to the stricture. And these actually show up, one by one, which is why we kind of see this as a, beads on a string kind of appearance. And this can kind of take part in, ducts that are inside the liver, like here or even here. But at certain points, you can also see it in the bigger ducts down here, which is kind of denoted here. So you see, this common bile duct, you see a stricture right here, and then you also see some of the dilations that happen over here. So sorry for the really rushed kind of experience, but I do have a section open right next to the gift shop. I have 2 seats open, and we can join each other in this virtual space and kind of talk about the models in detail. So please do join me. Happy to have you in virtual reality. Thank you.
Our next speaker is Dr. Armando Rashudo, who is a staff gastroenterologist in the Division of Gastroenterology, Hepatology, and Nutrition at the Hospital for Sick Children, Sick Kids. Her areas of specialty include pediatric inflammatory bowel disease and IBD-associated liver disease, particularly primary sclerosing cholangitis. She's also an assistant professor in the Department of Pediatrics at the University of Toronto. Thank you.
Okay. All right, so thank you for the introduction, and what a pleasure it is to be here this morning following those 2 really excellent talks. That virtual reality introduction to the liver was really, really fun. So today, those are my disclosures. So I was tasked with talking to you about studies in pediatric PSC. Obviously, that's a huge topic, so we'll just, sort of look at a little piece of it. But I thought we could actually start by taking a bit of a step back and talking about levels of evidence and study design so that you're a little bit more educated when you do see a study come out in terms of evaluating the rigor of that study and whether you sort of believe its findings, because not all studies, not all evidence is created equal, and I think it's really important to bear that in mind, especially when it comes to pediatric research on a rare disease where it's difficult to perform large randomized controlled trials. And then we'll talk a little bit about the Paediatric PSC Consortium, which is a very large international retrospective registry of pediatric PSC, and then finish by talking about some ongoing studies that are very exciting. All right, so as I mentioned, not all evidence is created equal. This is sort of a pyramid summarizing the levels of evidence when it comes to research on therapeutic interventions. So at the top of the pyramid, we have the RCT, or the randomized controlled trial. In fact, at the very top, what you have is systematic reviews of RCTs. So if you're in a situation where you're fortunate enough to have multiple RCTs on a topic, you can actually synthesize them and come out with sort of an average effect for an intervention. But in terms of an individual study, the RCT really is the gold standard for assessing interventions in terms of their efficacy as well as safety. Why are RCTs considered king when it comes to study design for therapeutics? It's because they minimize bias the most. So whenever we're conducting a study, we want to minimize bias as best as we can. And so you can see towards the top of the pyramid, you have a lower risk of bias, and as you move down towards lower levels of evidence, the risk of bias goes up. What is bias? Bias is essentially systematic error or a systematic deviation from the truth. So of course, when we conduct a study, we hope to be able to detect the true effect of an intervention, but a bias is something that's pulling the findings away from that actual effect. And RCTs do the best job of mitigating that risk. So this is another summary essentially of levels of evidence comparable to the pyramid that I just showed. So again, a level 1 or step 1 would be systematic reviews of multiple well-performed RCTs, and then in step 2 we have our RCT. So what is an RCT? In an RCT, patients are randomly assigned to receiving a treatment or no treatment. Most of the time, the no treatment group will receive a placebo where they can't tell the difference between whether they're in the treatment group or not. And the reason randomization is so key is that it balances factors, including unknown confounders, which I'll talk a little bit more about later, between groups, so that both the treated and untreated groups are similar. As a result, any difference in outcomes that's measured can then be attributed to the treatment and not differences in the groups. Although RCTs are again the gold standard, just because you see a study, published that's an RCT doesn't mean that it's automatically sort of golden and you should take it at face value. There are other factors that need to be considered, many other factors. I've not listed them all out here, but I've tried to list some of the ones that I think are particularly pertinent to PSC. So one is, what outcome was used, and is it a meaningful outcome? Of course, with PSC, it would be great to be able to study progression to liver transplant or cancer development, really meaningful hard outcomes. But those are things that develop really slowly, and it's difficult to have sufficient resources to conduct a large study that can follow patients out that long. So if you look to the adult trials in PSC, a lot of the time the primary outcome will be a change in a liver enzyme, usually alkaline phosphatase, or in pediatrics we talk about GGT. And while that's probably related to outcomes to some extent, it's not really been shown that an improvement in those metrics is associated with a definite improvement in those hard outcomes that we really care about. So that's one initial limitation when it comes to studying PSC, is that we tend to use shorter term surrogate outcomes, and it's hard to study the longer term meaningful ones. Sample size is of course important. An RCT in 1,000 patients is not the same as an RCT in 30 patients. And then generalizability. Are the patients included in the study similar to me as a patient, where I can expect that the findings described are applicable to me? And RCTs are quite strict. They exclude patients for a number of reasons. So it may be that there are characteristics about yourself as a patient that would actually have led to your exclusion from the trial. So those are all things to keep in mind. And I just wanted to talk a little bit about this concept of confounding because it is so important. So a quick example, if we're interested in studying the association between maybe coffee exposure and developing cancer. So let's say we set out to study this and we found that people who drank more coffee were more likely to develop cancer. This would lead us to conclude, well, yes, coffee is a risk factor for cancer. But what if it so happens that people who drink coffee are also more likely to be smokers? We know that there's a very clear association between smoking and cancer. So really here, it's the smoking that's muddying the picture. And if we hadn't thought about smoking as a potential confounder, we would have assumed that coffee was a risk factor, when in fact it's smoking. So smoking would be a great example of a confounder here. It's associated both with the exposure or the treatment, in this case we're talking about treatments, and with the outcome. And the reason that RCTs, again, surpass the other study designs is it's the only design that can balance known but also unknown confounders. So there may be factors out there that are potential confounders that researchers haven't even thought about yet, but the act of randomizing patients means that even confounders that are unknown will be equally balanced, and an RCT is the only design that can do that. Now that being said, as I've alluded to, RCTs are tough in PSC. They're tough for a disease that is rare, and that's especially the case for pediatric PSC, for a disease that is slowly progressive, because again, it's a question of feasibility and having sufficient resources to enroll a large enough number of patients and follow them over a long enough period of time. And as I've mentioned, we tend to be forced to use surrogate outcomes, again, for feasibility reasons. So because of all those difficulties with conducting RCTs in pediatric PSC, you'll see that a lot of the research specifically in pediatric PC is what we call cohort studies or observational studies. I'll talk a little bit more about that now. So the next level of evidence, what's presented here as level 3, would be non-randomized, meaning observational studies, non-randomized controlled cohort studies. So the word controlled is really important because what that means is that there's a comparator group. So we're not just looking at patients who received a treatment and studying their outcomes, but we're comparing them to an untreated group. And that's really important because if we don't have an untreated group and we observe changes in a treated group on its own, it's really impossible to say if those changes are due to the treatment or perhaps they would have just happened over time, for example. We know that PSC is characterized by natural fluctuations in liver enzymes over time. So it's really important to have a comparator group. And then in the setting of an observational cohort study, we don't have randomization to balance out our confounders, but we can use statistical methods like regression, propensity score, et cetera, to try to adjust as best as we can for known confounders. But we can't manage unknown confounders, right? We can't adjust for things that we don't know about. Within cohort studies, there's another big branch point. There's a distinction between prospective and retrospective cohort studies. Prospective studies are generally considered more rigorous, but they're more labor-intensive and more resource-intensive. Retrospective studies are easier from a feasibility point of view, but more susceptible to bias. So just a quick look at the difference between the two. So in a retrospective study, we're looking back at things that have already happened. We're completely dependent on data that's already been collected, oftentimes in medical records or sometimes in administrative data. So for example, we could look back at sick kids and say, let's look at kids who received a specific treatment versus those who didn't, try to get that information from the medical chart, and then compare outcomes as they're recorded in the medical chart. It's not as high quality as a prospective study because, as I mentioned, we're dependent on what's been collected. And if not everything we need is there, we're kind of left to guess as best as we can a little bit. And there's also often a lot of missing data when it comes to retrospective studies. A prospective study, we're studying something that hasn't yet occurred. So we're following patients in real time. We can ask the questions and collect the information in the way that we specifically want to for the question at hand. So more rigorous in that fashion, and we have a better handle on missing data. We can try to minimize that better. And then at the very bottom of the evidence pyramid is everything else. So any description of a group where there's no control group, so we're just reading about a group of patients who've received a treatment with no comparator group, case reports where you're reading about sort of individual patients and outcomes there, and expert opinion, not based on evidence generated through studies, that's all sort of at the bottom of the pyramid. So hopefully that helps to orient us a little bit to some of the studies that I'll talk about. So moving on to the Paediatric PSC Consortium. As I mentioned, this is an international registry of pediatric PSC. It's huge. It includes almost 1,400 children with PSC around the world across about 50 centers. It is retrospective in design, so bear in mind the limitations that I've mentioned about retrospective studies, but it's a trade-off. There's no way we could perform a prospective study of 1,400 kids. So here we're gaining sample size, but sacrificing a little bit on sort of the rigor of the evidence based on the retrospective nature. And this, in my opinion, really generated the definitive description of the natural history in pediatric PSC. This was a paper that came out a while ago. At that time, there were about 800 kids included. Overall, 14% of patients required a liver transplant during the pediatric period at about an average of 4 years after diagnosis. 88% of kids did not need a liver transplant by 5 years, and 70% did not need a liver transplant by 10 years. I wanted to briefly mention the SCOPE index. It's a risk score for predicting outcomes in pediatric PSC, but it's notable because it's the only risk score that was specifically developed in a pediatric population. I'll skip over the details of exactly how that was done, but essentially it was developed against a meaningful outcome, which was survival with native liver or essentially not needing a liver transplant. So these are the items that figure into the SCOPE index. Bilirubin, which is a substance that's excreted through the bile ducts. Albumin, which is a protein level in the blood, and that's made by the liver. Platelets, which can go down in the setting of a cirrhotic liver. GGT, which of course can be a marker of biliary injury, and then whether there's large duct involvement, that's detectable on MRI. Patients get categorized into 3 risk groups, either low, medium, or high risk. In yellow, what you see are probabilities of needing a liver transplant over the next 5 years, and those probabilities only really start to meaningfully increase in the high risk group. And the SCOPE has outperformed the other risk scores that were developed in adults. Just a brief word about vancomycin, specifically for treating IBD associated with PSC, because it is such, a hot topic in the world of PSC. Prior to the analysis of the Paediatric PSC Consortium, there were some very encouraging case reports and case series of using vancomycin for treating the colitis associated with PSC. But these were case series, so they really were at the lower end of the evidence pyramid. I'll go through this quickly for the sake of time, but we made use of that large registry of 1,400 kids to look at using vancomycin for improving the colitis in patients with PSC. This is all retrospective again, but essentially we created a matched cohort of 70 kids who got vanco to 210 kids who didn't have vanco. So this was the first study of vanco for PSC IBD that had a control group, and it was by far the largest. Without any adjustment, we found that patients who got vanco had a 65% chance of being in clinical remission from an IBD point of view, compared to 35% of patients who did not receive vanco. There are many confounders in a study like this. The vanco patients may have received other treatments that could have impacted their IBD. They may have had milder or more severe IBD than the untreated group. So this large table is just summarizing all of those various parameters that we tried to adjust for statistically. And in doing so, we actually found that the advantage of vanco was higher than before making those adjustments. Patients who got vanco had 5 times greater odds of being in clinical remission compared to the untreated patients. We found a similar effect size between patients with Crohn's disease and ulcerative colitis, and we also saw a benefit in the smaller subset of patients who had endoscopic data available, and we also saw a benefit for some labs like CRP, which is an inflammatory marker in the blood. So with that study, we've shifted the evidence a little bit for the use of vancomycin for IBD PSC from sort of the lower end to a little bit towards the middle end, but still recognizing that this is not a gold standard RCT. Recommendations around vancomycin for PSC are a little wishy-washy. I think the consensus is, and as I've shown, there is no grade 1 evidence to support its use, but there is some evidence when it comes to the IBD, some lower quality evidence like what I've summarized. And when it comes to the PSC, I haven't specifically gone into that in this talk, but the recommendation from the pediatric group at the top is that it may be considered for treating PSC, and from the adult group is there's insufficient evidence to recommend it, but again, they don't say there's sufficient evidence to recommend against it, so it's a little bit of an unknown. And just to mention that when we perform these studies, we're looking at medication use at a population average level. But as I'm sure you've heard about, there's a big shift underway right now away from a one-size-fits-all approach to treating patients to healthcare that is individualized, and recognizing that every patient is unique in their biological traits and their social determinants. And so it may be that on average in an RCT, a treatment is not effective, but that doesn't necessarily mean that it's not, beneficial in a specific subgroup. And thus far, we haven't really been very good at studying interventions in that way, but hopefully with this shift towards precision medicine, we'll start seeing more of those types of studies. I'll skip over this for the sake of time. I wanted to finish up by talking about 2 ongoing studies in the world of pediatric PSC. This one I think is quite exciting because in contrast to the registry study that I mentioned, it's a prospective study. And it's from the Children Group, which is the Childhood Liver Disease Research Network, which brings together over 10 sites in Canada and the US focused on different liver diseases in childhood. There are various aims, including defining the different phenotypes of PSC, so PSC associated with autoimmune hepatitis overlap, for example, and PSC with IBD, quality of life, and also creating a biobank to further precision medicine studies that will hopefully allow a more granular look at the disease. And then I'll just mention that the A-Link study is being led out of Cincinnati, sort of a quality improvement initiative with both a retrospective and a prospective piece. And maybe we can direct you to some information online about that because I'm told that I'm out of time. That was essentially it. So thank you so much for your attention, and I think we have some time for Q&A.
So while everybody is getting ready for Q&A, what I'd like to say is, because we started just a touch late, and I apologize, the Q&A will extend till about 10 after the hour. If you need a longer break, feel free to get up, and if you need to use the restrooms, they're upstairs. And let's start with our virtual Q&A. Do we have the virtual Slido Q&A too? Is there any audience questions right now to start with? Raise your hand and they'll bring you the speaker. Don't be shy. Do you have a question? While you think, and while Slido is going on, I get to ask a question. Dr. Prosciutto, I was wondering, for the children's study, if somebody lives in a rural area, do they have access to participate in that study?
So I believe if a person is able to make it to the study site regularly to satisfy sort of the requirements of the study, that they could potentially be eligible. I could do a little bit more digging on that question to confirm definitively, but I think that's the situation. The patient needs to be able to get to the hospital in question.
Okay, thank you. And Slido isn't up. Anyone else with a question right now? Yes.
Hi, I think this is a question for Dr. Hirschfield or whomever, but there was a slide with the C's, and on the cholangitis portion, there was a reference to environmental factors that have some association. I was wondering what those were.
Well, I think it's a great question. So, if you take a step back, every disease is a mixture of genes and environment, and PSC is no different. And by that I mean, we're all different and we all encounter different things, okay? And when they collide, how your body responds, be that the bugs in your bowel or your immune system, will lead to change, okay? For PSC IBD, what we see is that there are some genetic signatures that make PSC more likely, but they tend to be, they're very much around the immune system and they're only a small contributor. Then we assume that things in the environment come along and trigger it. And what we don't know is whether those things are environment for the bowel, which trigger colitis, so something that changes your bugs or changes how you respond to your bugs, or something in the liver, something that your liver excretes. When we look at, say, PSC IBD across Ontario, we can see, and other people have done this in the UK and elsewhere, that there does seem to be differences where people live. So it looks like there's a bit of a bias to being more rural. Okay, or, there's a bit of a bias to socioeconomics. And by socioeconomics, what I mean is that, I always say this, our PSC patients are our nicest patients, okay? But actually, when we look epidemiologically, their wealth gradient is slightly higher than some of our other diseases. They tend to be a little bit more affluent. That's not to say you're all rich, but, there tends to be an affluence gradient for PSC where there isn't an affluence gradient for some other diseases. And that might suggest that something in their diet, or what they're exposed to, or the fact that they live further away from toxic sites, might be relevant. So we don't know what the environmental trigger is, but we have a lot of evidence to suggest that it's relevant. And likely what happens is that it's many different things in the environment, and it may be different things for different people, which is why it's so hard. But when you have three things, subtle genes, subtle environment, and then there has to be a little bit of bad luck because they have to collide, okay? Then in an individual, they get the inflammation, and then for whatever reason, which we, again, we look to Sonia to solve, it's just not as good at turning the inflammation off, okay? So there's the beginning, the foot on the pedal, but the brake also seems to be slightly less efficient for our patients with PSC. Because in fact, as I told you, the liver's really very forgiving, and it does everything possible to turn inflammation off and to stop inflammation becoming scar tissue. So it's actually those three things. So that's a long answer to say we don't know.
Thank you. Here's a question that either or both of you can talk about. At what age do you recommend starting to transition from pediatric to adult care, and what activities should that include?
It's a really great question. And I think transition for a condition that has, liver involvement and gut involvement is even more challenging than transitioning a child who's got just one or the other. There's not really a specific age, but definitely we want to try to not be talking about transition only at the visit. Your birthday's in 2 months from now, we better figure this out. So I would say it's a gradual process. As we follow our kids, we want to be giving them increasing independence and ownership of their disease, making sure we're directing the conversation to them in the clinic, asking them about what medications they're taking and encouraging them to take ownership of that. In terms of sort of reaching out to our adult colleagues, again, we'd like to initiate that early to make sure that everything's kind of nicely in place when they turn 18. And I'd say at Sick Kids and TGH, we are endeavoring to have joint visits as much as possible with the adult hepatology provider so that introduction can happen while the patient is still on the pediatric side, so that it's a little bit easier and more comfortable, a little bit less anxiety provoking, hopefully. There's currently, speaking of RCTs, an RCTs under process to look at specific supports for transitioning in the world of IBD. It involves what we call a transition navigator, which means you get a person, could be a nurse or a social worker, who's sort of specifically assigned to you and to the patient to help make sure you have the knowledge that you need to transition well. There's a series of educational modules. So I could imagine that if something like that is shown to be effective in the IBD sphere, it certainly could be applicable to PSC IBD. So I think we'll be seeing more of those kinds of tools coming through.
Thank you very much. Another audience question? Yes.
I have two questions. The first question is about screening. I just want to know what age or what times should they start screening, for example. Number two is cultural. Is there more culturally diverse in specific skin tone, skin color? Does that play a role as well in developing PSC?
Why don't you tell them what you do at Sick Kids, and I can tell you how we screen the adults, and I can answer the other question.
Yeah, so the question of screening is so hard in pediatrics because these events are fortunately so rare. Colon cancer and cholangiocarcinoma are exceedingly rare in the pediatric population. So when it comes to things like bile duct cancer and liver cancer, the recommendations are not to do specific screening for it. Now, we do regular imaging through MRI and ultrasound about once a year to monitor on the progression of PSC in general. And imaging is largely, the screening tool for things like cholangiocarcinoma as well. There's also a blood marker, CA19-9. The official recommendation is that it's probably not very useful in the pediatric age range. We do it more so for academic purposes than anything else, I think. And then on the colon cancer front, again, difficult to address. There are some more specific guidelines that are coming out, including that pediatric guideline that I mentioned. So I think everybody agrees that sort of under the age of 12, the risk of colon cancer is so rare, it's probably not justified to do regular screening every year with colonoscopy unless there are specific additional risk factors. Those risk factors would include having had colitis for a long time. So let's say you're 13, but you were diagnosed with your colitis 10 years ago, we would start implementing the regular screening. If there's a family member who was diagnosed with colon cancer at less than 50 years old, or if you're someone who's had really difficult to manage IBD for a while, those are all added risk factors for colon cancer. And then once you start to get to sort of the mid-teenage period, we feel it's probably reasonable to start applying the adult screening practices. Number one, because a 15-year-old's not too different from an 18-year-old, and it also starts to get people used to what they'll be experiencing on the adult side in terms of an annual colonoscopy.
Yeah, we're pretty similar. I mean, essentially, once you transition to the adult services, on average, if you've got IBD, you'll probably be having a colonoscopy every 1 to 2 years. And in terms of imaging, well, you know, we do some form of imaging, usually MRI in our practice, but it's some form of imaging once a year. Recognizing that, you know, it's not perfect, but fortunately the actual, the bad news is on the rare side. It's not on the never side, which is why we do it, but it is in fact the exception rather than the rule. But actually what we do tend to do is we talk to the patient and let them sort of, certainly once they're over 18, you know, let them be guided by their opinion as well as to, you know, what works for them. So we you know, there's no hard and fast. As to sort of, you know, heritage, I mean, I think it's a great question. There are differences in how PSC looks around the world. If you have PSC in Japan, it's actually quite rare in Japan, then the Japanese patients do not have inflammatory bowel disease very often. It's much less common for them to have inflammatory bowel disease. If you go to Europe, there's a gradient between north and south, where PSC is more common in Northern Europe and less common in Southern Europe. If we look across America, then, you know, we need more data on heritage, and clearly our data is still biased towards Caucasian populations, mainly because there is a probably more PSC in Caucasian heritage, but there is data for African American PSC. There is, you know, conflicting data about whether or not it has a different sort of natural history. It is quite hard to untangle healthcare disparities, and by healthcare disparities I mean access to healthcare, okay, from biology, you know, as to whether things are just different from an immune system or an environment perspective. So it's definitely something that's on our radar, particularly somewhere like Ontario, where we really can do that study, to try and learn more about it. Although it's not as easy a question as you ask, because you really have to get quite sophisticated to understand what is heritage. Okay, it becomes very complex. But it's definitely something that we think is relevant, and presumably genes. Genes are different. Your immune systems, we all have different what's called HLA patterns, and your HLA patterns are what present what you encounter in the environment. Okay, so we know that our HLA systems are different for everyone in this room, okay? And that's the fundamental way your immune system works, in fact, to present what it's exposed to. So it's a great question.
Other questions? All right. It is time for a break. I'd like to say thank you so much to all three of our speakers. Excellent. We appreciate everything you've done. Thank you so much.